Just going to hit. We really wanted to have a quick update on monkeypox, as there's a lot of new information coming through. So Sumaya Asid, our pharmacy ASB expert, and myself, Dr. V.
Hi, Dr. Horn.
We will go through some of the monkeypox information, and please ask questions as everything is new and developing. So just a quick background about monkeypox. The first case of known monkeypox was in 1970 in a 9-month-old child. Ever since then, we have had multiple outbreaks, but they've been very small since 1970 to 1979 in different parts of in Africa. And mortality, there was an outbreak in 1986, reached about 10%. And there's been small outbreaks ever since in Central and West Africa. So that's kind of like a little background of monkeypox, where everything started. Pathogenesis, there's 2 different monkeypox strains that we have seen, Central African and the West African clade. And the mortality has been a little different so far. Classically, the Central African Congo Basin clade historically causes more severe disease. And thankfully, that's not the current clade.
Yeah, there are 2 different types, and one is worse than the other, and that's right. Thankfully, it's not the one that's worse. So, it's looking like it's the one that's not as bad, and I think part of that is how severe, right?
Yeah, and the mortality. So currently the clade is the West African and not the Central African. But currently they're saying the data about mortality in this recent times, anywhere between 3 to 6%, but data we're still getting in the United States, we have not had any mortality, but they are starting to report some cases in.
Yes, there were some deaths. I think it was in Spain, and I think there was one in India.
And Brazil,
yes,
so
yeah.
in Europe. So they're starting to see mortality, very few cases, but it's starting to happen.
Yeah, early with these kind of outbreaks and things, it's hard to tell what the mortality is going to be. And so that's something that we'll get more information, as we get more information and see how people do, we'll have a better idea about the mortality.
So far, it sounds like a lot of immunocompromised patients it's affecting. So something to keep in mind. Again.
Yeah, so here's just another way of looking at that same information. So there's a Central African strain, and the Central African strain has a higher mortality than the West African strain. And it looks like, we're seeing the West African strain that is the one that is causing this big outbreak. And despite its name, monkeypox is actually a misnomer, since it most commonly infects small African mammals and rodents. But it got this monkeypox name, and then it kind of stuck. And that's kind of what happens in medicine, I think, is it gets a name and then it's hard to change or get away from that.
I know they discussed about changing the name, but I'm not sure where we are on that still.
Right. People think of monkeys, and it kind of leads you to a not,
it's a stigmatizing way.
Yes, and it kind of gets you not focusing on the right things, or gets you thinking about monkeys when it just kind of is a distraction.
Yeah. So just a quick update. This data is from yesterday. As of yesterday, there's 26,000 cases worldwide. And as of yesterday, in the United States, we had 6,600 cases. CDC website is really great. They will break down, give you current US numbers and world global numbers. And, certain states are having way more cases, for example, Illinois and California. I also think New York, they have declared medical emergency, a state of health emergency. And I think that just gives you more resources to be able to handle the outbreak. And certain states still low, but I don't know if it's low because we're not testing and looking for it. That's a big concern for me.
Yeah, no, I think that's a really good point, because we'll talk about the symptoms and signs in a second, but there are classic symptoms and signs, but how it's presenting in patients now is a little bit different than what's expected. And so, the how aggressive people are in testing people and looking for it is one of the things we wanted to focus on during this presentation, and how important it is to, when you hear someone has a rash or someone has symptoms, to keep in mind that, could it be monkeypox? And even if it doesn't fit exactly, it's really important to still have a high suspicion and still ask a lot of questions. And, I think that's something that we really want to talk about.
Just more awareness. So CDC defines what is a case definition, right? So suspected case, a new rash, or meets one of the epidemiological criteria as high clinical suspicion for monkeypox. So that's a suspected case that we might see. Probable case is no suspicion of recent orthopox exposure, and demonstrate the presence of orthopox DNA or using immunohistochemical methods, demonstrate level of antibodies. This kind of gets confusing a little bit, suspected, probable, but let's talk about confirmed or real cases. So demonstrating the presence of monkeypox DNA. It's isolated in the viral culture, and having close epidemiological ties, like within the 21 days you have infection, you had contact with somebody who had monkeypox, you traveled to a site that had monkeypox cases, and also, come in contact with exotic animals and stuff. But one thing that's really concerning is they're saying travel outside of United States for countries with confirmed cases. At this moment, we have the we have the highest number of cases worldwide. Over total cases 26,000. We have over 6,000 cases, so we're leading in numbers.
Right. So if someone doesn't have, with these epidemiologic criteria, they want to have a link, like an exposure, but it gets out of date pretty quickly, as you're saying. Yeah.
And I think, like, we can't say, oh, did you travel outside of US? Then we have internal transmission. So just be aware of those questions. And it's also updated a little while ago, so it needs to be updated now. Signs and symptoms. So nice pictures, chills, muscle pains.
Yeah, and lymphadenopathy. So none of these things are they're not going to lead you to monkeypox, and some of them happen in kind of a lot of different diseases and conditions. But if you hear about this, it's good to have a high clinical suspicion. So if someone comes in with a rash, any kind of skin lesion, lymphadenopathy, fever, fatigue, in addition to thinking of the things you would normally think about, and add on, could this be monkeypox, and should they be in isolation, and these things.
Yeah, and we're going to talk a little bit about infection control, because how important, especially in healthcare settings, right? Incubation period, anywhere between 7 to 14 days, but can take up to 21 days. Yeah,
so when people are describing symptoms to you, it's good to keep in mind of this monkeypox outbreak, and there isn't, the rash can be characteristic, or but it may not be, and that's why any disturbing, skin rashes, and it's good to have a high clinical suspicion of monkeypox, and add that to your differential.
And then, so those are classic symptoms, but also recently what we're seeing is that, there are certain groups of people that are higher risk at this moment. So men who have sex with men, community. And then also we're noticing lesions in genital area, penile, testicle, labia, vaginal area. And then of course, other areas as well, chest, mouth, face. So it's really important to ask when we look at, do you have any lesions if you're suspecting, to talk about, do you have any lesions in your genital area as well, to include that. And also remember, monkeypox is spread through contact. There's kind of been a little bit of a misinformation, I think, also, because there's a lot of focus on our gay community, which is, I think, the right thing to do, because there's higher amount of infection. So we need to get vaccinated and give access. But at the same time, anybody can get monkeypox from contact. So just have to have that high degree of clinical suspicion for that.
Yeah, and I think this is, some of the older ID doctors were saying how just as HIV started in the gay community and then spread everywhere, that this is starting in some communities, but it's still important to think that it's not isolated to those communities, and everyone is still at risk. And so, yeah, I think that's a really good point.
Yeah.
And this slide is highlighting the recent sign and symptoms. So instead of the classic signs and symptoms, they have to keep changing, the signs and symptoms to look for, because it doesn't present as it historically was thought to.
When we were in school, we were taught that the lesions are all come up at the same time and they all same stages. But what we are noticing now is that the lesions can be different.
Yes, and I think that it's very important to know that, because if you think, oh, they must look a certain way, they must all be on the same stage, then you don't want to exclude people that are presenting now with different symptoms. And here you can see there are some lesions on the hand. Generally, people always think of syphilis when they see lesions on the hand, which is a good thought, but also include monkeypox here. There's another picture of one here, and then there's one on the thumb. So this looks like a pustule, so it's got pus underneath there. And then you've got several here on someone's back. And here you have additional small pustules, and then here this is an umbilicated one. And to these, it looks like it has an umbilicus or a belly button.
And that's important because in kids sometimes, or adults too, you could confuse it with molluscum. Yeah. So just keeping monkeypox as a differential when we see any type of these skin lesions is going to be really important.
Yeah, and that's a very characteristic look, I think, and something to keep in mind, that monkeypox can look like that. And if you're going to swab for these lesions, like the pustule on the other picture, you would want to unroof it, and then you would swab in there and get a good swab to be sent to lab, which we'll talk about in a minute.
So again, how do we spread monkeypox? Direct contact. So with a rash, scab, bodily fluid, skin to skin contact. So of course, if there's intimacy, then it's much closer skin to skin contact. But any type of skin to skin contact you can spread. And if their patients are having respiratory symptoms, then of course you could spread it respiratory wise. And let's say we admit a patient and we're intubating them, they have respiratory symptoms, then you could aerosolize. So there's some concerns for that. So that's why it's really important to wear the right type of personal protective equipment, including an N95, especially in healthcare settings. And then of course, now moms can also spread it to babies when they're pregnant as well. So vaccines and treatment, and we're going to turn this over to Samaya.
Thank you. Yeah, so I'll start with the monkeypox vaccines. There are currently 2 FDA licensed vaccines. These are actually originally smallpox vaccines. There's the Genios Vaccine and then the ACAM 2000 vaccine. The Genios Vaccine is thought to be the one that is the most preferred. These cannot be pre-ordered or pre-stocked in your pharmacy or in your hospital. They're still allocated through the health department. So nothing that we can order and be prepared for. Next slide, please. All right, so again, some of the same stuff I just mentioned. The Ginios vaccine is the one that's the more preferred vaccine. It's still a live vaccine, but it's non-replicating. And that's the main difference between the Ginios and the ACAM 2000, which again is the less preferred vaccine. This is inoculated as a live virus, and then it continues to replicate in the skin, and it could actually be spread to other parts of the body or to other people. So just something to be cautious of, especially like in our immunocompromised population. The recommendation is that these vaccines be given within 4 days of exposure, just for the best protection. And then usually full protection isn't until about 2 weeks after the second dose of the sub-Q vaccine. Next slide, please.
just to add to that,
Oh, yeah.
the ACAM 2000, I think they used this vaccine back in 2003 when there were cases. And of course, laboratory personnel and military personnel have gotten ACAM 2000 in the past. And if you were born before 1972, the vaccine campaign also used smallpox vaccine. So there's some cross protection when you had smallpox vaccine to now. 1972 or before, you probably got the vaccine. After that, we stopped vaccinating because smallpox was eradicated. But if you're exposed, health department can get you the vaccine if they have supply, of course. And you should ideally get them 4 days, like Samaya said, but you could get it 4 to 14 days after. But it won't guarantee you won't get the infection, but it might help reduce the severity of the infection. Just something to remember. Thank you, Samaya. Here is next slide for you.
All right, so obviously with COVID still going on, and then maybe the potential that we still have patients that need vaccine, or there's the new Novavax vaccine. This slide is actually directly from the CDC presentation on any timing interval we might need between giving any of the smallpox, monkeypox vaccines, and then any of the COVID vaccines. So just thought this would be good to have in case we do have cases where we are co-vaccinating. All right, so the next part I'll talk about is the treatments. So we have several treatments available. A lot of these are actually FDA approved and studied for smallpox, but a lot of the data is coming from in vitro studies or animal studies in humans with some protection against monkeypox. All of these are through an IND, or like compassionate use investigational drug through the CDC. So again, they're not really anything we can stock or have on hand in case we have a patient. And I'll talk about them a little bit more in the next few slides. So just a duplicate of what I said, these are again coming through the National Strategic Stockpile. So they're allocated through the CDC, maybe your health department, but nothing that the pharmacy or the hospital or the outpatient pharmacy can have in stock. All right, so here are the main treatments. The first one, Techoveromat, TPOXX. This is what is considered right now the most preferred treatment. This was FDA approved in 2018 for treatment of smallpox. Again, for monkeypox, it's used through an EA-IND, so an investigational drug application. It was studied in a small case study at 7 people for monkeypox. And it did show some good outcomes in reducing viral shedding and illness in 1 patient. But again, it was a very small subgroup that it was studied in. And in humans, it's shown very minimal side effects, so very well tolerated. The next group of antivirals are cidofovir and brincidofovir. So cidofovir is available. You might have it in your pharmacy. This was FDA approved in 1996 for CMV retinitis. Again, because this is off-label, this is for monkeypox. It's given from the CDC through an expanded access protocol. There's no real data on effectiveness in human cases of monkeypox, but again, it was studied in vitro and in animal studies. Because of that, we don't really know if it'll have good benefit for patients with monkeypox, but definitely something to consider, especially in severe cases. The benefit for using brincidofovir over cidofovir is that brincidofovir has a little bit less renal toxicity. Cidofovir is known to cause a lot of that, but there was a trial where they had 3 out of 3 people stop brincidofovir because of elevations in LFT. So a lot of like risk benefit analysis. And then the third option is the immune globulin. So this was again FDA approved in 2005 for complications from the Ginios Vaccine. For monkeypox, it is administered under the same expanded access protocol. There's no real data on the effectiveness of treatment right now for monkeypox, but it's definitely an option, especially for prophylactic use in patients with like severe immunodeficiency in T-cell, where you can't give a vaccine. So there is definitely a place for it, but just keep in mind that the first column, Techoveromat, is going to be our preferred, for now, treatment.
And just to give an update too, so I was wondering how to get the drug, so I kind of wanted a flow. So I called our local health department, and they said if we have a case, we call the local health department, and they will coordinate with the state health department, and then be able to get the drugs for us from CDC. So I think make sure we always contact the local health department to kind of help with that process as well.
All right, so Techoveromat TPOXX, again, is the most preferred. It does come in oral as well as IV. For the oral to work, it needs to be given with a full fatty meal. There are times you might benefit from the oral over the IV formulation, especially in our renal patients, and this is for adult and pediatric patients. There's specific restrictions in renal impairment, so that's when we might have to use the oral if we can. There is two significant drug interactions that we need to keep in mind. One with repaglinide, where hypoglycemia is seen, and then a significant interaction with midazolam, where there's decreased efficacy of midazolam. So this is something important to keep in mind, especially if we have an inpatient or someone that is sedated. These are the most common side effects with Techoveromat. Again, it was very well tolerated, so nothing exceptional. So right now, who's getting prioritized for treatment and vaccine? And these are specifically from the CDC recommendations at this point. So if we have patients with severe disease or they're hospitalized and at risk for severe disease, if we have a patient that's high risk due to being immunocompromised, young pediatric patients like younger than 8 years old, or high risk because they have other dermatologic conditions, pregnant or breastfeeding women are also high risk. And then if there's like monkeypox infections in weird areas or high risk areas, eyes, mouth, genital areas, these areas also come with significant amounts of pain for the patients. So I don't know, Dr. V or Dr. Horn, if you want to comment on prioritization for treatment or.
Yeah, so I would say all these groups are high risk. So being able to call for this, particularly this group of folks who either admitted or high risk and getting the treatment would be really good. You know, as I'm reading, you know, children under the 8 can be really severe disease, pregnant women, immunocompromised, HIV, AIDS. So I think it's really important when we have this high risk category, reaching out and making sure we are able to get treatment. And I really like what you said, Samaya, about like lesions and like very areas that can be very painful. And I'm hearing it's very painful, particularly in the genital areas, and it really helps to get antiviral. And of course, eyes are very, you know, you have to protect your eyes. So it's really important to get treatment. So this list is really good. And I think it's important to be able to use it. It's right out of the CDC. So I agree with you.
Dr. V talked about this a little bit, how to obtain Techoveromat. So depending on the state you're in, you can call your health department. There's also what I provided in that box, they're direct to the links for the applications. And I think as we're seeing more and more cases, the CDC is actually slimming down these applications. So it was like 20 pages and now it's like 5 or 6. So it's becoming a little bit easier, but it still does require all this paperwork and can't just be ordered. So I just provided all this information for you. This application or all the coordination needs to be done by the treating physician, and that's very specific in the investigational drug application. So it doesn't have to be, it can't be like the patient's primary care or the pharmacist. It needs to be by the treating physician because there's informed consent for the patients that also has to be submitted.
And we'll be sending the slides out after the presentation, and it has links to all this document, so you can all have that as well. All right, John and I are going to talk about now infection prevention. This has been a hot topic, so we'll cover certain areas.
So as far as what to wear when seeing a patient with suspected monkeypox, it's going to be gown, gloves, eye protection like goggles or a face shield, and then an approved respirator equipped with an N95. So it's going to be isolating the patient in a negative pressure room if possible, and then wearing essentially pretty much the same stuff as COVID, I think. Yeah. And contact and airborne. And so place the patient in a single person room. So if you have a negative pressure room, then that's where you would put them. And then keep the door closed, have a dedicated bathroom. And if the patient should leave the room, it's really important to make sure they're not going to spread it to other people in the hospital, whether they're taking care of them or to other patients.
Yeah, like let's say the patient goes to the CT scanner room, right? When you bring the patient back, making sure that CT scanner room is fully cleaned. The scanner, if they touched anything, so just being aware of like good cleaning processes.
Oh, and then as far as garbage in the room, that's actually an interesting topic that you're looking into.
So like, it's really important to close the door. Like if you don't have a negative pressure room, you could put them in a single room, like Dr. Horn was saying, close the room, keep all the linens and garbage in that room. And when people are leaving that room, they should take off their gown and gloves and put it in that room before they leave, and then do really good hand hygiene outside. And that garbage, those needs to be disposed as medical grade waste. Sorry. I forgot to take this one as I was looking up information. So it needs to be treated as medical grade waste. And I got this information from Department of Health in California. And what they're saying is it needs to be, so for example, some hospitals use Recycle. They come and pick up medical grade waste. And then at their facility, they like autoclave before disposing the material. So every facility, you got, following your local health department and your hospital policies, but know that the soil needs to be handled differently as category B waste is very important.
Yeah, and I think this highlights the importance of having a protocol or knowing what to do before the patient shows up, and not trying to figure this out when there's a patient and there's so much going on.
Yeah, what I'm hearing is a lot of places, Sumaya was telling us this too, the COVID-19 task force are now doing monkeypox task force work. And I think it's really good making sure you're ahead of the, before a patient comes. So talking about how do you isolate the patient? What will be the workflow? How do you manage, garbage disposal? How do you clean the area? Just having everything written down so there's no confusion and we do everything correctly.
Yes, and there are some stories, and I'm not sure if other people have heard about, if a patient shows up and the hospital is just not prepared at all. There's no protocol, there's no plan, nobody, there's a lot of confusion and nobody knows what to do. So
yeah,
it's important to kind of try and make a plan now and a protocol now, so it'll make it easier when that patient shows up unexpectedly.
Yeah, and I'm also hearing certain hospitals, because they didn't think about monkeypox as a differential, patient gets admitted and then there's over 200 exposure in the ER, in the hospital. So that becomes really, cumbersome for like infection prevention. And so it's really important to wear right PPE. So I think the message needs to be to everybody, if you think of a rash at this point, if you're considering monkeypox, right PPE, right isolation is going to be really important. And also it's important to know that as a healthcare worker, if we get exposed, what are the guidance from CDC and also anybody else that gets exposed. So if you're exposed to monkeypox, then you have to monitor for fevers, chills, lymphadenopathy, lymph nodes enlarging anywhere from neck to inguinal areas, under your arms, and a new skin rash developing. So it's really important to keep an eye out for those. And it's really important, if a healthcare worker is exposed, you have to monitor them then for at least 21 days after being exposed. Is it high level exposure or low level exposure? So healthcare workers is exposed unprotected exposure, not wearing PPE. They could still come to work, but the healthcare facility should twice a day monitor for symptoms, especially temperatures, for 21 days. That's a lot of work, right? For us, healthcare facilities already so busy. So that's why I think using this point to make sure everybody's wearing right PPE is going to be really important. But if a healthcare worker is exposed without a PPE, at least twice a day, temperature and monitoring and symptoms monitoring. And we should, in the healthcare facility, implement to watch them because they're high exposure. If a healthcare worker has cared for otherwise been in direct or indirect contact while the patient is adhering to recommended infection control, they may go self-monitoring. So then you could let the healthcare worker tell them, hey, watch yourself for 21 days. See if you develop any of these symptoms, don't come to work. So if it's lower degree exposure, you could do that. High degree exposure, healthcare facilities need to take responsibility and make sure we're monitoring them.
And then as far as exposure risk assessment, there are different degrees, right? So there's degree of exposure. If they have a high degree of exposure, then the recommendations, it's to monitor them. And then
and they go into like detail, and this can be found on the CDC website. So high degree is unprotected contact between persons, skin and mucosal membrane. So really high degree.
You're right. And I think the main thing from this is just know this exists. And then if you get questions about exposure, know to go look this up and how to categorize their exposure and post-exposure prophylaxis.
Yes.
And who needs it and everything, and coordinating with your health department and everything.
That's really good that you said post-exposure. So we have post-exposure we talked about, but then there's also pre-exposure. So if you're, again, high risk community groups are now, they're getting allocated pre-exposure prophylaxis. And I do know that CDC has a small amount dedicated now to like healthcare workers that might be taking care of high-risk patients in the hospital. So each state is now getting allocated small amounts. Do you want to comment anything on that, Samaya? Have you heard about that too?
No, I don't have anything to add, but I have heard that.
Yeah, so they're allocating small amounts to each state. So, in your hospital, if you get allocated and there's 3-member group that are going to take care of them, maybe they'll be the highest priority, but very, very low numbers, but that is available as well. So these slides kind of talk about high risk, so no PPE. Moderate risk is like, the healthcare worker goes in, they might have a mask, but they didn't have a gown and they touch things and they get exposed. That's kind of intermediate risk. Low risk is you had all your PPE, but you might have not have your eye protection. So that's low risk. So for low risk, you don't need post-exposure prophylaxis, but for intermediate and high risk recommended. For intermediate risk, clinical decision making and talking to the individual, and it might be warranted. So they nicely categorize that. So just knowing it's there and you all can go look for what kind of, if you have an exposure, is important.
Mm-hmm. And then as far as key takeaways, consider monkeypox for fever, malaise, lymphadenopathy, if they have pustules, often involving the genitals. So if you hear about these kind of symptoms, it's important to ask the patient more information and think about monkeypox as a possibility. And then start developing a protocol now for your hospital. And this should be individualized for your hospital and your local health department. So when a patient shows up, you're prepared, and try and avoid scrambling at the last minute. And And that's because there will be some scrambling at the last minute, but you want to minimize that as much as possible. And then admit those who need pain management, like children under 8 years old, pregnant women, immunocompromised, patients that are at high risk or high risk of having bad symptoms. Those people need to be treated very aggressively, not only for themselves, but also to reduce the spread in those populations as well. And proper PPE, so that's N95, eye protection, gown, gloves, and to be very careful. And it spreads easily, but it's not something that spreads as bad as some other things. And so, it's important to be cautious, but as long as you take the proper precautions, I wouldn't, worry too much. I don't know how to, I don't want to worry people too much.
I don't think it's worrying. It's just taking all the proper precautions, and we know what will work. So just taking all those precautions will just prevent all that worry, and we'll be there to take good care of our patients.
Yes, as long as you wear the proper protection and everything, it's not something to be, paralyzed or anything. I don't want to scare people or anything like that. And diagnostic testing, 2 swabs of a single lesion sent in a viral transport media. And it's important, to talk to your health department and see exactly what they would like and how they would like it handled. So when you do collect some swabs, you can do it in a manner that will make sense for your local health department. And so you're not going in and doing it a second time or something if possible. And then the antivirals, I think Sumaya went through those very well.
And then, of course, Genios Vaccine is available to public health for high-risk exposure. So just making sure, I think communicating with your local health department is going to be really important. And those were our last slide. And we welcome any questions now, either in the chat or you could unmute yourself and ask us any questions. We're happy to answer.
And, I think this is a great topic. We'd be happy to talk about this again as things develop, as this continues to kind of unfold and we get more and more information. And, if I hope everyone found this helpful.
Yeah, and please email us if you have any questions or concern. I think the most important takeaway is going back to, if you're all healthcare facilities, and if you have already not started, just starting like a flow sheet at your facility, how you will be able to handle when things happen.
This is Renee. Oh, sorry, Whitney, go ahead.
No, hey, I was just about to say, this is Whitney Brown from Crisp Regional. I was just going to ask about the actual sample from the patient. So the biggest thing we ran into a mess with our first patient was really knowing where to send the sample, because we called the CDC directly, and they told us that if we already had, an arrangement with Quest to send that sample, to go ahead and process it that way. But it ended up being a 7-day turnaround. So we ended up collecting multiple samples from this patient and ended up ultimately sending it to the CDC for quicker processing, but it was 5 days later. What are you seeing as the best way to get these samples tested for these patients that are suspected of having monkeypox?
Great question. I think that's why it's really important to call the local health department. So we had a similar scenario where we call the local health department, and they already have a plan. Each state and health department has a plan, and they were able to direct me to the lab that they already figured out who will do it, and we got the results back in 48 hours. So I really would say start with your local health department, because they all have a plan now. And then asking, if they don't have a plan, then I think externally going to either CDC or commercial lab is okay. But starting at this moment, I would start with the local health department. And it was very helpful when I had that scenario happen.
Okay, great. Thank you for that information.
Yeah, thank you, Whitney. And I think we have a question here. Do you recommend disposable gown for healthcare workers? And what about curtains in the room? Yeah, very good question. So Disposable gowns are great because then you could just dispose them. If you have reusable gown, then it really needs to be cleaned appropriately as the CDC and the waste proposal. So a lot of the facilities are going to the easy way of getting rid of things at this moment. Unless if we start getting lots and lots of cases, then we have to reevaluate that. But yes, disposable gown is the way to go. And curtains, ideally, we shouldn't have curtains. If you have curtains, then probably a disposable curtain will be the better way to go, or have a process to clean the curtains. But yeah, any type of inside needs to be well cleaned. So if your EVS has a process to clean the curtain appropriately, I think it might be okay, but otherwise disposable curtains might be another option. Any other questions?
This is Samaya. I was just going to comment because I forgot to say this, and I've been getting a lot of questions about this. So if there's recommendations for all healthcare workers to get pre-exposure prophylaxis if you are not, already vaccinated from when you were born or from occupational. And as I've been reviewing the guidelines, there's currently not a recommendation, even for like our higher risk, like lab workers or ED physicians, to all just be mass vaccinated right now. I guess that could change with our stock or how the cases go, but I know there's been some concerns from healthcare workers if we should all just get vaccinated, and that is not the current recommendation.
Yeah, great points, Maya. I don't think, first of all, we have enough vaccines of the Genios vaccine. And secondly, though, if we all wear proper PPE, we should be fine. So I think that's the key message now, is wearing proper PPE, and then identifying these cases earlier, so we do so. And I do think things might change as we get more vaccination. I think getting frontline workers to get Genios vaccine would be a good idea. We're just not there yet because I don't think we have enough vaccines of Genios vaccine. There is ACAM vaccine in the United States. There are over 100 million ACAM vaccine, ACAM 3000 vaccine, but it's in our stockpile. But they have not released that yet for this purpose because, again, like we talked about, when you get ACAM 3000, you have to keep the site closed. Sometimes because it's a live virus, it's okay in immunocompetent people, but if you're immunocompromised, they could get a serious infection. And then if you could get there's some side effects from ACAM 3000 too. But I do think personally, as ID physician, I think it's a good idea if, for immunocompetent patients, individuals, we give ACAM 3000 because we don't have enough Genios, but we're not there yet. Unfortunately, we're using Genios at this moment and the vaccine is low. So they're prioritizing for the group that needs it the most. Any other questions?
Hey, this is Rebecca Worley. I'm one of the pharmacists with Whitney at Crisp Regional. This may be kind of a crazy question, but I've had it posed to me already. The generation that has already been inoculated for smallpox, is that immunization still viable for the monkeypox?
Yeah, that's what they're saying.
Yeah, I believe there was a patient that had been previously vaccinated, and I want to say it was about it was over a decade. I think it was probably, I want to say 16 to 19 years before, and they were exposed and they did okay, but that was just, we don't have enough data yet. That was just, I think there were just a few patients that they were able to look at and say it looks like it continues to protect people, or it does protect people for a very long time, is what it looks like when the preliminary information. But yeah, no, that's a very good question.
Yeah, and that's a good question. Like, especially if you were vaccinated before 1972, there is some protection. We just don't know what degree of protection, but definitely there will be some protection. We just don't know if it's 70%, 80%, 90%, so more to come. But but that's what we are hearing at this time. There's another question. Did you say we
dehood the swab? So unroof the swab. Yeah, I believe that was the recommendation, was to I think it was at least one of the two swabs that should be unroofed. I believe that's what it was.
Didn't you have a case?
I did. I saw a case very early in It was already unroofed to the patient that I saw, but there was one that was unroofed and I swabbed that, and then there was another one that I did unroof and swabbed there as well. That patient actually didn't end up having monkeypox, and our local health department, they could test for orthomyxovirus, and they tested that and it was negative, and they had another alternate diagnosis that was more compelling that it was consistent with. But yes, I believe that was the recommendation, was to if they have pustules, to unroof it and swab the pus that's there.
Great question. Any other questions? Well, thank you so much for joining us. And please let us know if you have any more questions, and we will keep updating you as new information comes in. Have a great day.
Thank you, everybody.